Hey, what's going on, guys, and welcome back to another video of Keep It Simple Stupid. Today we're going to be discussing a very basic topic here, and that's going to be aortic dissection, but specifically aortic dissection management. And again, as always, I'm going to try to make it as simple as possible. So let's go ahead and get started. So the first question before anything else we need to ask ourselves is, what exactly is an aortic dissection? And I'm going to go ahead and explain that. So this is, again, my excellent drawing of an aorta. Now, if you can use your imagination here, your heart is right here. Right, so here's your aorta, and then it goes down into the abdomen, become the abdominal aorta, and then you see you have your branches here, so your brachiocephalic, which is going to be here, left common carotid, left subclavian. Now, the important thing to understand about an aortic dissection is the specific pathology behind it, and to demonstrate that, I have another drawing to show you. Again, this is our same image here, but the important thing to understand is that in the layering of the aorta, there's three components. There's the intima, then the media, finally the adventitia. Hopefully you can read my handwriting there. So for the purposes of this lecture, you really don't need to understand adventitia at all. The important thing you need to know is that a dissection is a tear between the intima and the media. Now, if we can use, again, our imagination here, look at our aorta here, right? And this inside line, this will represent our intima. And then this outside component will represent our media and our adventitia. As you can see here, I've demonstrated with the dark red, this is going to be the blood flow, right? So follow those. And essentially what's been created with that gap between the intima and the media is a false lumen, okay? Now, the important thing to understand is, why exactly is this dangerous? Well, if you have a weakened aorta and it keeps getting larger and larger, eventually it becomes so weak that it could potentially rupture, it could potentially continue down, or it could continue up, causing dissection flaps that could cause neurologic symptoms. So it's a life-threatening emergency. But again, the important thing to understand for the pathophys of an aortic dissection is you have a false lumen between the intima and the media. Now, moving to the next component of the lecture, we're just going to discuss causes. And the important thing to note here, and I've already written it out, anything increasing pressure or weakening vessel integrity. These are going to be the big players and the things that could lead to a dissection. Now, to kind of break it down, one of the big ones is going to be poorly controlled hypertension. Another big component here is going to be hereditary illnesses. So if you think like Marfan's or Ehlers-Danlos syndrome, right? So again, those are going to be kind of the big things to keep in mind. Think anything that weakens the vessel or anything that increases pressure on the vessel. Those are going to be your causes. One of the most important components here is going to be treatment. Now, if we think to the pathophys, right? So you have a dissection. What is going to make it worse? It's going to be increased pressure. Now, one of the biggest components, understanding that, is that you now want to treat it, you want to decrease anything that is putting more pressure on that vessel wall. And what are those components you want to keep an eye out for? That's going to be heart rate and then blood pressure. Right, so HR for heart rate and then SPP for systolic blood pressure. Now, the important thing here is the goal for these values is that you want to have a heart rate less than 60 or a systolic blood pressure less than 120. Now, that is very important because this is going to lead us to the next component of this, and that is going to be, what medication are you going to want to give? Now, you can take a minute here and you can guess, but I'll go ahead and write it out, okay? And the big player in this is going to be something called esmolol. The important thing about esmolol, you've probably guessed by the last name, right? The LOL ending. This is a beta blocker, okay? Now, specifically, it is a beta 1 antagonist, and this is going to be very important for decreasing that heart rate. And then this will lead us to the next component, and that is going to be, what is the initial dose? And that's going to be 500 mics per kilogram. And then what is the maximum dose? It's actually going to be 300 mics per kilogram per minute. So the next question now is going to be, so what is a good second line agent in case you've maxed out on that esmolol and stay your heart rate's still like 110, your systolic blood pressure is going crazy? What other options are there? And there are two, and they're in the same class. That's going to be nicardipine and clofidipine. These two medicines, they both are pure arterial vasodilators. For nicardipine, you're going to want to know the initial starting infusion. It's going to be 5 milligrams per hour. And then for clofidipine, your initial dose is going to be 1 to 2 milligrams per hour. This is for the acute stabilization. Now, these patients will need definitive treatment by either a CVT surgeon or a vascular surgeon. Maybe they'll want to deploy an endograft or do a bypass, but it's kind of out of the scope of this lecture. But again, I just want to make a very simple video about the acute treatment / management of aortic dissection. And then the final component, and I didn't want to get into this, but to diagnose the dissection, the gold standard is going to be a CT angio, which is essentially where the contrast is timed so that you can see it in the vessel lumen to see if there is that false lumen. Well, all right, guys, that's all I had for you today. Just wanted to cover the acute management of aortic dissection. A shout out to my subscribers. I think I'm over 50 now, which is really cool. I still haven't really gotten any specific requests for topics, but if there is something you'd like me to cover, please let me know. And until then, like, comment, subscribe, and I'll see you guys next time.